Hello, good evening, good morning, wherever you are. Welcome to Stevie MD's ECG workout. Today we're going to tackle another case, which I shared on figure one. So without much ado, I think we should just go on to viewing the cases. Okay, so let's do that. I'll share my screen and then we'll start. Wow. So here we are. Case one, where we had a 63-year-old man who presents with chest pain, shortness of breath, and then we asked what the findings are. So with a very quick look at this, medical students in their clinical years should be able to pick out quickly what we are seeing. Like I have always said that these videos are not going to take us back, from the basics. So before you come in here, the basics on how to analyze an ECG, checking the rate, rhythm, the axis, and all that should have been done already by you. So without much ado, we could quickly analyze the ECG, and we could tell that this is a sinus rhythm. We have the P's coming from the SN node, reaching down to the AV, and so it's a sinus rhythm, yeah? When we look at the lead 2, lead 3, AVF, which are the inferior leads, then we see the ST elevation of the, yeah, the ST elevation going on there. And then we are also seeing reciprocal ST depressions, okay, in V1, V2, V3. So straightforward, we could just pick out inferior myocardial infarction. It's so obvious to pick it up. So that will be the first findings or diagnosis. Then what is more important here? Let's zoom in to analyze. So when we look at V1 in particular, we have a number of P waves going on in there. Let me take my pen. So what are we seeing here? We have a lot of P waves in there. We have a lot of P waves. So this is one of them. And then there's another one in here, which is buried in the ST segment. There's another one here, and that, and that, and that, and that, and it goes on, right? So this is what we call the E-POLYURIA. It's just a term not too technical. It's just a fancy way of saying there's a lot of P waves in the ECG strip, right? So there's electronic polyuria going on with a lot of P waves, of course. And then again, if we have a case like that, we have to map the P waves. Okay, so you map the P wave to track every P wave where you could find or detect a P wave, a hidden P wave. Mostly they are hidden in the ST segments or in the T wave. Okay, and when it's on or it's in the T wave, mostly the T wave gets very pokey and or very peaked, I would say. So we have to map them. So mapping them, we could map like that as I've done here already. Okay, you map them and you map them. So you could see that um, they are actually, even in this QRS complex, you could see that the tip of it is very peaked. It could be that there's a very P wave in there. So mapping going, we keep mapping, we keep mapping. And some of the P waves, you realize that they are not conducted. They are not conducted P waves, okay? So what comes to mind whenever you have such a situation? Whenever you have such case, you first have to think about the AV blocks. So check for the PR intervals for your AV blocks. And we know the AV block, the first degree, the second degree, which has the Mobis 1, Mobis 2, and then we have the third degree, which is the what? Complete heart block, right? So let's quickly just go through what the blocks are. So we know that the first degree AV blocks, we have there's delay of conduction of the electrical impulse at the level of the AV node, which is causing the prolongation of the PR interval, right? And then usually the AV block is benign, but if the AV block is associated with an acute MI, it may lead to further, AV block defects. So that is just to take note, okay? Okay, so in this case, we can't say that we're having a first degree. No, it's not happening like this, okay? So second degree, which has the Mobis 1 and then the Mobis 2. So let's take the Mobis 1 and see the Mobis 1, the PR intervals become progressively longer until one P wave is totally blocked and produces no QRS. Okay, so after a pause, where is my pen? So after a pause during which the AV node recovers, the cycle is then repeated, right? Folks, my pen is missing. Oh my goodness. Okay, so yeah, right. Okay, so in this case, in Mobitz 1, there's no way you're going to have two non-conducted P waves like what we're seeing here. So this cannot also be a Mobitz 1. Okay, this cannot also be a Mobitz 1. So let's look at the Mobitz 2. Okay, Mobitz 2, the conduction ratios could vary 2:1, 3:1, or 4:1. And we have the QRS complexes being region wide because the block is caused by what? A bundle branch block, a right bundle branch or left bundle branch, right? In this case, like we are seeing, so normal, upright, and uniform P waves, and then you have more P waves on the QRS complexes. But here's the catch. The PR interval is normal, okay? And it's constant, it's not progressing. But look at this. So you have this, right? PR interval, and then now look, PR interval, and now look, and now look. It gets prolonged as it moves on, yeah? It's progressively getting prolonged. So this cannot also be a Mobitz 2. This cannot be a Mobitz type 2, okay? So if this cannot be a Mobitz type 2, then we only have a complete heart block, right? And then with a complete heart block, what we're seeing is that there's no what let me just have a clean sheet. With a complete heart block, the P waves and the QRS complexes are not in sync. Okay, that means that the conduction between the atria and the ventricles is absent because of an electrical block, either at the AV node or below the AV node, right? So this is the case we're seeing here. This is a complete and obvious um, complete heart block, a third degree. Okay, here you see that the P waves could be normal, okay, upright or in uniform, and they may be superimposed either on a QRS like I showed here, or on the T wave. Okay, sometimes, like in this case, we are only having ST depression, so and even that there's a buried T wave in there. Okay, so that is what normally happens for third degree AV blocks. Okay, so the QRS complex is normal if ventricles are activated by the junctional escape focus, and it is wide if the escape focus is coming from um, the ventricles. So right now we having a complete heart block. Now the question is, where is the escape rhythm coming from if there is a complete heart block? And I just said the answer. So it could be coming from the junction, or it could be coming from the ventricles itself. Okay, and then how do you tell the difference between a junctional escape rhythm and uh, a ventricular escape rhythm? So mostly with the junctional escape rhythms, what you have is that the rate is normally between 40 to 60 BPMs, and they could be narrow or wide. Okay, sorry, that is with um the junctional escape rhythms, yeah, could be narrow or wide. And when they're wide, it's probably due to the bundle branch block, right? And then typically between the rate of 40 to 60, like I said, and then the ventricles, well, I mean, when the escape rhythms come from the ventricles, they are normally wide. They are typically wide and with a rate of 20 to 40. So this was a strip here to show us a type a type 1 Morbitz, okay, that I just wanted to show. Okay, so you see that there's what a progressive increase in the QRS, and then there's a drop on the QRS complex, on the PR interval, and then a drop. Okay, so these ones are easy to pick out. Okay, so this was the case where we had an inferior MI going on. We have a right bundle branch block as well, because looking at the V1, okay, looking at the V1, okay, we see the right bundle branch block morphology. Okay, let's not forget that the right bundle branch block has very unique patterns. It could be the RSR, okay, it could be the one with the rabbit ears as well. Okay, and sometimes even the QR morphology as well. So easy to pick up. Okay, right bundle branch block with inferior MI, and we also had what escape rhythms going on. Okay, a junctional escape rhythm as well, and a complete heart block. That was it. That was it. Okay, so there is another case, which was a 24-year-old woman who presented with palpitations, and she had a history of rheumatic heart disease with mild mitral stenosis and moderate mitral regurgitation. And then what do we see? So this was another case. I think this case was similar to a case I shared earlier. And what did we find out from that case? Or what are we seeing here as well? So let's quickly go through that. Let's quickly go through that. take a pause and then try to analyze the ECG. Just take a pause and try to analyze this ECG strip. A lot of comments came up when I shared it, actually, and I was impressed with the answers or with the suggestions. I was really much impressed. Yeah. So, quick one. So, this was the case called the Ashman's phenomenon. The Ashman's phenomenon. Okay, this was the Ashman's phenomenon, and we already talked about it in my previous video about the Ashman's phenomenon. You could just go in there and have a look at it on my YouTube page. Okay, so we said the Ashman phenomenon. Normally, you should have what? You should have a long short or a short long intervals. I mean, between the RR intervals. Okay, for instance, in V1, mostly you have a long to short parting, and then the next beat is going to be a right bundle branch block, like we're seeing here. Okay, so whenever you see this, just know that this is Ashman's phenomenon going on there. And it's mostly accompanied by the atrial fibrillation, like we're seeing here. Okay, the RR intervals are not equal. And so this was a case of atrial fibrillation with the long short right bundle branch parting in B1. And then we concluded that this was Ashman's beats, or we have Ashman beats, and then the whole thing was an Ashman phenomenon. Okay, the whole thing was an Ashman phenomenon. Sometimes, for instance, you could have PVCs in there. For instance, when you're having equal intervals, RR intervals, and then you're having such a morphology. And when it's not actually, typical in the, when it's not showing the typical right bundle branch morphology, you could say that this could not be an Ashman bead, but rather a PVC. So this would probably be a PVC, right? So yeah, and that was that for this case, typical Ashman phenomenon. And then you know how to go about this condition by just doing a rate control, or, if not, just hit it up with a cardioversion, and then you're good to go. Okay, so that was that for the cases. So we're going to just end here and then pick up another case next time. So just stay tuned and keep in touch. Have a good day and enjoy yourselves. All right, stay healthy. Bye-bye.